Hey guys, it's James from Kind Health, and today we've got a really good question. It was a tough one, so if there was an award being handed out for someone who could ask the toughest question, I would say for me this has been the toughest because I work on the health insurance side where we try to help people find plans and understand how to use those plans when it comes to the shopping experience. But this question centered on the side of insurance where insurance companies are basically paying doctors incentives. So it's a fantastic question, and it helped me actually grow in my knowledge. So I'm going to go ahead and read it to you, and I'm going to lean heavily upon my notes in this one as we try to tackle the answer to this question. So it says, I spent over 3 months working with a health insurance company in Nashville last year, drawing pretty pictures of their financial data and never fully understood how all of the bonuses work to incentivize doctors to provide more preventative care and avoid costly procedures. So again, this was a tough question, and I had to do some digging. I actually reached out to a few providers themselves, a couple of insurance executives, and then of course leaned heavily upon Kaiser Family Foundation to do some of my reading. But basically, as it goes, the way incentives work with doctors, traditionally, they've been paid under a fee-for-service model, and that still goes on to a certain degree, even most of the time now. But basically, fee-for-service means that for each service that's performed or each procedure that's done when you visit the doctor, there's a fee directly associated to that. And so if you are usually going, let's say, to one doctor for one set of symptoms and another doctor for another set of symptoms because one's your neurologist and one's your cardiologist, and they're not sharing notes and they don't necessarily work on the same team, nor are they under the same umbrella, you're paying basically to have tests run at both places, and so you might have redundancy. Also, under fee-for-service, there's basically a financial incentive for each test run. So in some cases, a doctor might run unnecessary tests because there is that financial incentive there. I want to give doctors the benefit of the doubt, though, so that's said somewhat in a negative light. In a more positive light, the way that could work is, or one way to understand it is, there's no financial disincentive for running extra tests when it comes to being a doctor or provider. So let's say that when in doubt, the doctor might say, go ahead and run the test because then I can know for sure, and it's not like there's any financial disincentive for doing so. So you have basically overcare and sometimes redundancy because there's not a lot of information being shared. Well, what the Affordable Care Act has tried to do under this sort of reimbursement change or this shift towards reimbursement changes is to incentivize doctors who get together and actually cross-collaborate and work together as a team rather than just paying for each individual procedure that might be done. So what does that look like? I know that sounds like a lot of words so far, but not a lot of tangible meaning. So I reached out to one provider that I know well, and this is what I got from her. So she said that basically programs now exist that utilize an interdisciplinary team. So that could include a doctor, a physician extender, a social worker, a physical therapist, etc. So a physician extender meaning like a physician's assistant or a clinical nurse specialist or nurse practitioner. But it's an interdisciplinary team that works together in order to create programs that closely follow up with the patients in an outpatient setting or clinic to better manage chronic health issues. So one example of that is that one hospital actually created a heart failure clinic where the patient literally follows up as often as once per week so that the clinic can closely monitor health status to prevent the patient from coming back through the ER due to something like shortness of breath. So it seems as though there is a big issue when patients actually return after treatment, and especially if they return through the ER. So again, they're building interdisciplinary teams that not only work together to ensure that they're getting the best care and treatment that they can get, but also trying to educate them and give them home resources so that when they do send them away, they're equipped to basically take care of themselves and remain in a healthy state rather than going back to a bad condition and then returning through the ER simply because they were shortness of breath and weren't sure what to do after they saw the doctor. So an example of some home resources would include a walker, home oxygen, home healthcare visits, medication, education, discharge planning, and of course ensuring family or friends are there to help, etc. So those specifics can change from person to person based on their situation, but these are examples of what doctors are doing and the way that their behavior patterns are changing based on new incentive models. And so to get more specific to the heart of the question, how do these insurance incentives work and incentivize doctors to do it? Well, the place that we've seen it the most is actually under what's called ACOs, so accountable care organizations. And again, I'm going to lean on Kaiser to explain it a little bit, so I'm going to actually read their exact definition. But an ACO is a network of doctors and hospitals that share financial and medical responsibility for providing coordinated care to patients in hopes of limiting unnecessary care and spending. And so again, it's the main goal is to get away from that fragmented care where one doctor is treating one part of the body and another doctor is treating another part of the body, but rather bringing together these teams and saying, hey, if you guys can all work together, the amount of money that we're going to save in redundant or unnecessary testing and procedures because you guys are collaborating, all the money that will be saved will actually provide an incentive back to you for becoming more efficient and restoring that patient to health. So they have high benchmarks placed on them to ensure that the quality of care is not going down, but that doctors are also seeking to be as efficient and collaborative as they possibly can. So here's a few details on what ACOs have experienced since they've come about. According to Kaiser, in 2014, the third year of Medicare ACO programs, 97 ACOs qualified for shared saving payments of more than $422 million. So again, in summary, the goal is that financial incentives exist for doctors and teams of doctors to come together and work together in collaborative care manners, and when they send patients home, to ensure they have the education and resources to stay healthy and not return for the same exact issues or return through the ER. Like, let's say if a 65-year-old man was dealing with shortness of breath, but he also happens to have heart disease, and he just simply returned to the ER because he had heart disease. The goal is that he be educated and fully understand when he should come and visit the doctor, or what could be a routine call, rather than saying, oh no, I'm dealing with shortness of breath, let's just go straight to the ER. So I hope that clears up that question. It was definitely a tough one. Again, it was how do insurance companies incentivize doctors to move towards preventative models rather than unnecessary procedures. So again, it's a push towards organizations like ACOs, accountable care organizations, and interdisciplinary teams who work together, share their notes, share their information, educate the patients when they go home. That way, everybody in the end ends up saving. So if you have more questions, just reach out to us on Twitter. It's @KindCares. And of course, stay tuned to our YouTube channel, and we'll continue to update it with videos, answering really good questions, and doing our best to answer them as well as we can.